we're spending a lot of time arguing about a test that's already been ordered and is normal. And Stuart, I just wonder if we should be moving on to ask the question, what should we be doing next? Because I think that's really what we're arguing about, but we're still focusing on the chest X-ray, which we've already...
That's a good comment. Let's do that. Okay, she comes back in another couple of weeks, and now we've got hemoptysis. So now, of course, you need to go into action mode. What do you do when you find hemoptysis?
This is, I mean, hemoptysis is one of those red flag symptoms where you need to determine the cause of hemoptysis, and it certainly raises your index of suspicion for a malignancy, even in a non-smoker. My response here, and bearing in mind we've already done a normal chest X-ray, would probably be to do two things: to organise a CT scan of the lung, bearing in mind that as a GP I'm not allowed to order an MRI, but a CT of the lung and the mediastinum. But I'd probably also be getting on the phone to Chris and saying, look, I've got a relatively young patient with no real risk factors who's presented with a persistent cough and hemoptysis. Can you see her fairly quickly to see if she warrants a bronchoscopy or other investigation?
Definitely, and can I just go from the rural perspective, that's definitely the case. And one of the things that's just an absolute joy in the rural perspective are your general physicians, because it gives us a chance to get some advice over a broad spectrum and then to narrow down. One of the bigger side effects, though, is access, and it's a constant issue for us trying to get, if this patient was rural, trying to get a rural patient into a city centre in a timely fashion. We don't tend to organise the higher level investigations. We tend to flick them straight to the specialist unit as soon as possible, because it's done quickly that way.
Chris, how are you? How's it all going?
Good, thanks, Simon. How are things?
Good. Is it convenient at the moment? I just need probably a minute or two of your time.
Yeah, no, it's fine.
Look, I've got a patient who I was wondering if you'd be able to advise me on and probably see. It's a really nice, otherwise healthy 60-year-old lady who doesn't have any particular risk factors for lung malignancy or other lung problems for that matter, but who's had a persistent cough for a few months and now has some hemoptysis. Chest X-ray we've done has already been normal, but I'll send that along with her. I'm assuming you'd like me to organise a CT before she sees you, which I can get done in the next 24 hours or so, but is there a chance you could see her for me in the next week?
Yeah, that sounds fine, Simon. I guess, did you mention that that you've sent some sputum for cytology and evaluation? I guess we could do that while she's coming as well. But she lives locally, does she?
Yeah, she lives locally. And having been a rural GP, by the way, before I was a metropolitan GP, we often used to joke that we could get patients into Prince Alfred faster than our colleagues from Narrabeen could, because, in fact, the city specialists were actually very good usually when taking calls from people in the country. The sputum cytology one's an interesting one. I really wonder these days whether, if I was making this call to Chris, whether I would go to sputum cytology because the sensitivity is relatively low, and I'm assuming that Chris is going to go to a bronchoscopy, but I'd be interested in his thoughts as to whether I should do that routinely.
So that sounds fine. I'll get the details from you, and we'll try and squeeze her into the clinic tomorrow or the next day, if that's all right, and we could take things from there. Sputum cytology, as an aside, if someone's got hemoptysis and there's a reasonable suspicion of lung cancer, it's a useful test because it's non-invasive, and in experienced hands it can give you the diagnosis of lung cancer without any more invasive testing. So if it's available and it's easy to do because the patient's got appropriate symptoms, we would often do it. I guess depending upon what else is happening as well, but it's easy to do. And generally, I guess we would do it at the clinic level rather than perhaps in general practice in this sort of situation. Yeah.
And bronchoscopy?
Well, I guess this consultation would be with a view to bronchoscopy. The patient would arrive with the CT that Simon had mentioned. We would generally then take a history, do a physical, look at the X-rays, and depending upon what the CT showed, make a decision about the diagnostic testing, which would be perhaps a bronchoscopy, but perhaps a fine needle biopsy or something else. So it depends a little on the CT. Yeah.
Okay.
Look, we are concerned and these are the possibilities.
But couldn't it be pneumonia or pleurisy?
Yes, it could, and we would need to have that
Yeah.
discussion. Yes, definitely.
It could be a number of things, but when people cough up blood, Kathy, it's a sign that worries us. It tells us that there's something there more than just a simple bronchitis, and we need to find out what. There's some sort of significant inflammation or irritation down there in the lung.
I really don't think it could be lung cancer because I don't smoke, and my husband gave up in the 50s. When he was in his 50s, and he used to smoke outside because I can't stand the smell of it. So it cannot be lung cancer.
It's very variable, depends where it is. I mean, it could be a small tumour in a proximal airway that's bleeding, or it could be more extensive tumour elsewhere that's doing the same thing. Yep.
I had a look at a study of primary care presentations, which is a fairly large study in Denmark, and 6% of patients presenting with lung cancer presented with hemoptysis. So it's actually quite rare for us to see hemoptysis, even in association with lung cancer.